Dr. Scott Turner. Dr. Turner is a vice chair and professor in the Department of Neurology and also director for the Memory Disorders Program at Georgetown University, Washington, D.C. He's a board-certified psychiatrist in psychiatry and neurology. Dr. Turner research has focused on developing new treatments and biomarkers for neurodegenerative diseases for aging, particularly in mild cognitive impairment and dementia due to Alzheimer's disease. He directs numerous multi-center, randomized, placebo-controlled clinical trials and research studies. Today he's going to talk on Alzheimer's disease and how to keep your aging brain healthy. Welcome, Dr. Turner.
Thank you for the invitation. It's a pleasure to talk about Alzheimer's disease today. One of the most common questions that I get is, what can I do to avoid having to make a clinic appointment in your clinic? A lot of people don't necessarily want to go to a memory disorders clinic, and I can understand why. So we're going to get to some of the things that you can do to protect your brain health as you age and prevent cognitive decline with aging, which we call mild cognitive impairment, and then as it progresses, we call it dementia. So the good news is that everyone is living longer, and on this slide, this shows the life expectancies that are increasing across the world. There were always some countries that claimed that they never had Alzheimer's in their country, but as their life expectancies are getting up to the 60s and beyond, it seems like it's also occurring there. So it's affecting every country in the world as life expectancies increase. On the left half of this slide are the number of people who are reaching age 100 in Japan. And so you can see the increasing life expectancy there. And there's a very similar curve in the United States. So the good news is we're making progress with heart disease, cancer, other disorders so that people are living longer. There's been a little bit of a hit from the opioid epidemic and then more recently from COVID. But in general, life expectancies are still increasing across the globe. On the next slide, so the good news is that we're having more years in our life, so we're getting more quantity of life. The bad news is that the longer you live, the more likely you're going to have a problem with dementia, and particularly Alzheimer's disease, which is the most common cause of dementia. Dementia is the more global term. There are many, many causes of dementia, but in advanced countries, the most common cause is Alzheimer's disease. So this slide shows you the increased prevalence of Alzheimer's disease with age. So it starts off in the 60s, 70s, and then increases, doubles every 5 to 10 years, so that by the time you're 85 plus, about 30% of Caucasians will have Alzheimer's. And it's about double this in Hispanic and African American populations. And we don't really understand why. This is one area where we need to do more research and try to understand why this is. There are environmental theories, there are genetic theories, but basically we're not sure why exactly the Alzheimer prevalence should be higher in African Americans and Hispanics compared to Asians and Caucasians. So the good news is we're living longer. The bad news is we're running into this more and more of this Alzheimer problem. And that's shown on the next slide. So in the green dots here are the number of people with Alzheimer's in the United States. So you can see we currently have about 5 million to 6 million people with Alzheimer's, diagnosed with Alzheimer's in the United States. And unfortunately, this is projected to increase, as you see in the green line here on this slide, up to about 12 to 13 million by age 2050. And on the blue is the projected cost of the Alzheimer epidemic, or what we call the silver tsunami. A lot of the costs are going to Medicare and Medicaid for diagnosis and treatment, but a lot of the costs fall to the families, particularly, for example, nursing home placement, memory placement, living situations that are outside the home, or hiring home help. A lot of the costs fall to the family to care for their loved one with Alzheimer's disease. The red line at the bottom is the investment in research in Alzheimer's disease. The good news is there has been a big increase in investment in research to try to find new treatments that we're going to talk about a little bit later. So on the next slide. People come to our clinic with memory problems, mostly older people complaining of memory issues. Some come sooner than others. Some come in the what we call the worried well stage, where they're perfectly normal and we do all our evaluation and we say it's just normal aging, everything is fine. We can't find a diagnosis. We call these individuals worried well. Others come in the very early stages of memory loss, where they're bothered by their memory decline, and others are starting to notice this. They're repeating things, forgetting things. And then others come in where the dementia is more advanced, and even some come in where the behavior problems are out of control from the dementia. They want the behavior problems managed. So when we see someone in clinic, our first job is to make a diagnosis. So as I mentioned, dementia is the global term, but Alzheimer's disease is the most common cause of dementia in the United States. Probably the second most common diagnosis in our clinic is Lewy body dementia, which has some features of Parkinson's associated with it, such as slowness and stiffness, sometimes visual hallucinations, seeing things that aren't there, usually animals or people. Sometimes with fluctuations, like very marked fluctuations, like someone can be pretty with it one day and then very demented the next day and then fluctuate back and forth. And a lot of the patients start off with Parkinson's disease, which is the tremor and the slowness and the stiffness. And these people also tend to fall a lot. So this can be distinguished from Alzheimer's disease and has a very different pathology and treatment. The next most common cause of dementia is frontotemporal dementia. This presents with behavioral problems, sort of disinhibition, sort of lack of any social inhibitions, doing things that are socially inappropriate. Some people present more with a language problem, difficulty with producing speech, for example. Other causes, multiple strokes. Approximately half of the people who have HIV infection will develop some memory problems. And this is called HAND, or HIV-associated neurocognitive decline. Other causes, depression, drugs which may be impairing memory. Someone can be an alcoholic and become demented from alcoholism. Chronic traumatic encephalopathy, which the football players are being increasingly diagnosed with lately. Hypothyroidism, B12 deficiency, other rare causes. And at the very bottom of this list is neurosyphilis, which means syphilis has been untreated and is infecting the brain. And 100 years ago, this was the #1 cause of dementia. So there used to be nursing homes with people with dementia from neurosyphilis. But of course, now we hardly ever see dementia due to neurosyphilis, and this has been replaced by dementia due to Alzheimer's disease. So on the next slide, the risk factors, as I mentioned, was #1 is aging. So all you have to do is age, and you increase your risk for Alzheimer's disease. And we talked about how the risk increases with age. The second most common or most important risk factor is having a family history of dementia or Alzheimer's disease. And there are some genes that increase your risk. There are about 100 families in the world that have a very rare mutation that causes early onset Alzheimer's, familial Alzheimer's, and these pedigrees have the onset in the ages of the 20s, 30s, and 40s, and half of the pedigree has early onset Alzheimer's, so they sort of stand out from all the millions with the late onset sporadic form of Alzheimer's. They're pretty rare, but these mutations have taught us a lot about what we think causes Alzheimer's. The more important risk factor is the ApoE gene, and so we have 2 copies of the ApoE gene, one from our mother, one from our father. And about 25% of the US population has the high-risk variant, which is the ApoE4 variant, which increases your risk of Alzheimer's. If you have 1 copy of ApoE4, you're about 3 times the risk of people who don't have this variant. And if you have 2 copies of ApoE4, which is pretty rare, you have about 8 times the risk of getting Alzheimer's disease. So this is probably the most important genetic risk factor for Alzheimer's and sporadic Alzheimer's, which is what the majority of people have present in older age. Down syndrome, individuals get Alzheimer's in their 40s and 50s. And as we already talked about, African American and Hispanic have higher risk than Caucasian and Asian. And this may be due to genetics or maybe environmental or probably some combination of both. So in yellow are the big 2 risk factors, but there are lots of other minor risk factors. You'll note that number 1 and number 2, you can't really do much about. Obviously you can't stop time and you can't choose your parents. But there are lots of other risk factors on this list that you can do something about. And these are what we call the modifiable risk factors. Diabetes is probably the most important on this list, which increases with obesity and poor diet. Metabolic syndrome, hypertension, also risk factors. Having a traumatic brain injury with loss of consciousness any time during your life increases risk. Smoking, having a history of a stroke, lower education and occupational level, air pollution exposure, and females may have a slightly higher risk than males. So the white ones are the modifiable risk factors. So this slide is probably the most important one tonight, and these are all the things that you can do to try to not have to make an appointment in the memory disorders clinic. And this is sort of listed from the best evidence to the least evidence. So probably the most important on this list is getting exercise and physical activity, at least 3 to 5 times a week, at least 30 minutes per session, enough exercise, hopefully to get a little bit of short of breath or a break of sweat. And there's lots of evidence to show that if you do everything on this list, you could probably delay or prevent dementia and Alzheimer's disease by at least 5 to 10 years. Next most important is keeping ideal body weight throughout your life, eating a Mediterranean diet, which is mostly a plant-based diet, with fruits and vegetables, very little in the way of processed foods, sugar and red meats. No solid fats. If you want to use a fat, use liquid fats such as olive oil. And having more education is also protective, limiting alcohol consumption, keeping mentally active, socially active, with social connections, avoiding traumatic brain injuries. For younger people, this means things like using seat belts and helmets for sports. And for older people, it's usually fall prevention strategies. Getting good quality, adequate sleep, no smoking, minimizing stress, avoiding air pollution if this is at all possible. If you need glasses, you get glasses and use them. And if you need hearing aids, you get hearing aids and you use them, because you don't want to deprive any information getting into your brain. So you don't want sensory deprivation. You want to make sure you keep your brain stimulated, and then if you need glasses and hearing aids to do that, then you get them and use them. Treat hypertension, diabetes, cholesterol, sleep apnea, depression with your healthcare provider that you're seeing on a routine basis. And if memory problems do develop, then seek an evaluation, get tested for thyroid disorders, vitamin B12 deficiency, and maybe syphilis and HIV with your healthcare provider. So as I said, do all those things and you can try to avoid or prevent having an appointment in the memory disorders clinic. But even if you do all these things, you're also going to live longer. And as we mentioned, aging is the #1 risk factor. So on the next slide, you can still develop mild cognitive impairment and dementia. Even if you do all those things, you just develop them later or when you're older. And this is what we call mild cognitive impairment, where you begin to fall off from the pack and your memory gets worse than we would expect for normal aging. And the memory starts to impair your abilities to do things, you repeat things, you forget things, you lose things. And on formal testing, you develop some memory problems, which is, as I mentioned, is worse than expected for age and education. And then the MCI usually lasts 1 to 2 or 3 years, and then you progress to dementia. And dementia means that you're having memory and cognitive problems, but now they're also beginning to impact on your ability to function in your daily life. So you may have difficulty driving, you may have difficulty being in charge of your daily finances, you may have difficulty being in charge of your own daily medications, and you just start to have more and more difficulties and need supervision on what we call those complex activities of daily living. And then as the dementia progresses over several years, each year slightly worse than before, you eventually need help with dressing, bathing, grooming, walking, transfers, toileting, eating, what we call the basic activities of daily living. So the dementia goes from mild to moderate to severe. Next. slide, we do have medications that are approved for Alzheimer's disease, and you can see the year of approval here. You can see that the last new drug until this year was approved in 2003. 3 of these drugs are what we call cholinesterase inhibitors. They sort of support the neurotransmitter acetylcholine, which you need in your brain to make new memories. One of them sort of protects neurons from dying in the Alzheimer process. But there's been no new drug approved until this year since 2003. So it's been a very difficult road in trying to discover and find new medications, more effective medications. But on the next slide, what we have done, where we've made a lot of progress, is in what we call biomarkers of the disease. So these are features of the disease that help us with diagnosis, that help us with predictions of who is going to develop mild cognitive impairment and Alzheimer's disease. So at the bottom line there, you can see the MCI. This is when the memory goes downhill, and then you cross into dementia, and this is when the memory and cognitive function begins to interfere with your daily life. But these other lines are what we call biomarkers of the disease. And the one on the left is looking at amyloid in the brain. So amyloid is an abnormal protein that accumulates in the brain, is neurotoxic. And you can see that the amyloid is accumulating in the brain for a long, long time, 10 to 20 years, before you even develop any memory problems, where we cross into the MCI categories. So these development of these biomarkers is now not only helping with diagnosis, but helping us to predict who is going to develop Alzheimer's disease in coming years, and allowing us for the first time to set up prevention trials. So we can identify people who are still cognitively normal, and this is what we call the preclinical stage of Alzheimer's disease, and start and enroll them in prevention trials with anti-amyloid antibodies, for example. So the biomarkers have really come a long way in the last 10 to 20 years, whereas the treatments have not in particular, but we think that the development of these biomarkers is leading us and helping us to figure out, what these new treatments might be, and what strategies we can use, and what effective strategies we can use to get better treatments. So the next slide, these are some of the biomarkers that have been developed, and these are PET scans of the brain. So the 4 PET scans on the left are normal individuals. Their memory and cognition is completely normal. And the 2 on the right are a person with Alzheimer's disease. And these are PET scans looking at how much amyloid is in the brain and how much tangle or tau pathology is in the brain. So the person on the right has Alzheimer's disease, and the 2 people on the left are normal. But you can see these changes are starting in the brain, and these are the biomarkers from the imaging PET studies. We can begin to see these changes 10 to 20 years before the onset of dementia. And we're sort of having an internal debate in our field. When exactly does Alzheimer's start? Does it really start when you get memory problems, such as the person on the right? Or does Alzheimer's start with the 2 people on the left, when you begin to see all these pathologies accumulating in the brain, even though they're still cognitively intact? And you can think about, for example, breast cancer. Does breast cancer start when you have symptoms of breast cancer, when you have weight loss and bone pain from metastases and things like that? Or does breast cancer start when there are a few cells, they're cancerous cells, but they're asymptomatic? They're not causing any symptoms whatsoever. So, it's kind of a debate about when these diseases really start. Right now, we're still calling Alzheimer's disease when you develop memory problems. But there's been sort of a discussion and a debate about whether we should call the 2 people on the left Alzheimer's disease as well, because they're beginning to show all of these abnormal pathologies in the brain. And you can see the person on the left has the abnormal pathologies starting in the hippocampus, or what we call the medial temporal lobe or hippocampus of the brain. This is the part of the brain that you need to make a new memory. So someone with Alzheimer's disease, their old memories are usually pretty good and they're intact for a long time. But the most difficult thing to do for an Alzheimer patient is to make a new memory. So for example, if you ask them, what did I have for breakfast this morning? Or you give them a list of words to remember, they just cannot do it, But if you ask them something from 30 or 40 years ago, they would be able to remember that because that's an old memory. So making a new memory is the hardest thing for an Alzheimer patient to do. So next slide. As I mentioned, we've developed these imaging biomarkers to tell us who has Alzheimer's, who is going to get Alzheimer's. And this technology started with the glucose PET scan in 1980, MRI of the brain, amyloid PET, tau PET. These are the imaging biomarkers. And then the next generation of biomarkers was looking at proteins in spinal fluid from a lumbar puncture. So this is looking at amyloid and tau and neurofilament light, different proteins in the spinal fluid indicating these neurodegenerative diseases. And then more recently, there's been a lot of work in the blood test for Alzheimer's. This is something that we've always been looking for because the PET scans are expensive and the cerebrospinal fluid proteins are invasive, meaning that you have to get a spinal tap that nobody really wants to get. So we're trying to develop these blood biomarkers, and this has been really an incredible development in the last few years, that we're getting really good at being able to diagnose Alzheimer's and predict who's going to get Alzheimer's from a blood protein test, such as amyloid ratios, neurofilament light, phospho-tau, these different proteins in the blood that we can now measure to help us, again, with diagnosis and prediction and prognosis and who's going to get Alzheimer's disease. So they're not quite as good yet as the PET and the spinal fluid markers, but they're getting pretty good, and they're getting good enough that we can use them for screening. There's a lot of cancer screens that happen, but we're not really screening for dementias. And now that these blood biomarkers are becoming available, we can start doing screenings for dementia and Alzheimer's disease. So next slide, there's been several trends in Alzheimer's disease recently. One is this new technology of these biomarkers that have been developed. Some of them are imaging biomarkers using a PET scan, these cerebrospinal fluid proteins that we're measuring, and then more recently the blood proteins that we're measuring, the so-called blood test for Alzheimer's disease. We're shifting earlier in the Alzheimer's spectrum. Traditionally, we only diagnosed and treated people who have Alzheimer's disease when they get demented, but now we're focusing more and more in the mild cognitive impairment stage, which is the prodromal Alzheimer's. And now we're even focusing more and more on the preclinical stage, which is when these pathologies are starting to develop, but people are still cognitively intact, cognitively normal, and starting to do prevention trials for these individuals. When we do these clinical trials, our typical enrollment population is usually 90% Caucasian. And as I mentioned, African Americans and Hispanics have a higher prevalence of Alzheimer's disease. So we really need to increase our diversity. We've been trying to think of strategies to increase the diversity of the study population, because we don't just want to know if a medication works in Caucasians, we want to know if a medication works for everyone. Mm-hmm. And is it effective, and does it have side effects in everyone, or not just Caucasian. So we really want everyone to come forward and partner with us in these clinical trials and increase the diversity in our study population. And another positive trend has been more and more NIH funding for dementias and Alzheimer's disease, and this has been very much needed because I think finally society is realizing the impact of dementia and Alzheimer's disease is probably the one disease that has the largest unmet medical need as far as treatment in all of medicine, as far as I can tell. So it's been good that we've had more funding and interest and more research in trying to find new biomarkers and trying to find new treatments, more effective treatments for dementia and Alzheimer's disease. So next slide. So we have a memory disorders program at Georgetown, and we have several research studies that are underway. Some of these don't involve any drug treatment whatsoever. They're just trying to understand the disease process better and develop new biomarkers or validate existing biomarkers. And so these are the studies that are ongoing to try to look for new biomarkers. For example, we're collaborating with an investigator at Marymount University who is looking at language changes to help diagnose early Alzheimer's disease just from recordings of telephone conversations to see how language changes and can that predict who is going to develop MCI and Alzheimer's and use it for diagnosis as well. On the next slide, We also have trials that are testing new drug treatments. And you can see a lot of these new drug treatments are anti-amyloid antibodies. So because it's an antibody, you can't take it by mouth. It's a protein. It would be digested by your stomach. So we have to give it intravenously or subcutaneous injection. And so these are some of the antibodies that we are studying. And the one in the middle, aducanumab, was recently FDA approved in June of this year, but it's a very controversial approval, and we can talk about some of the controversy. We're not generally recommending it because the efficacy, the effectiveness is still being debated. There's no question it removes amyloid from the brain, but there is a question as to whether this actually makes the patient any better, or does it actually change the course of the dementia? And this is where the controversy is. It's also very expensive and not covered by Medicare or insurance, and it has a significant risk of side effect. So it can trigger a lot of inflammation in the brain, swelling and edema. And in one case, we just learned recently that there was a fatal side effect of swelling of the brain from this antibody. So there are other antibodies that are looking even more promising in the pipeline, and these are being studied at Georgetown and other places across the country. And some of these trials are closed to new volunteers, but some are open to new volunteers. And we're always looking for people in the early stage of Alzheimer's disease, mild Alzheimer's disease, or mild cognitive impairment, who would be interested in learning more about participating in a clinical trial. Our trials usually last 1 to 2 years, typically require a visit to the clinical research unit, which is part of the guts, for once a month for 1 to 2 years for the intravenous treatment or the subcutaneous injection. And so we're always looking for volunteers for clinical trials. And we estimate in our field that only about 1%, or probably less than 1%, of people with Alzheimer's participate in any research whatsoever. And so we really need to increase the numbers of people who join studies if we want to make progress faster. And on the next slide, as I mentioned, we've also launched prevention trials for Alzheimer's disease. So these are looking for older people generally, who are cognitively normal, no memory problems. But for example, they may have a positive amyloid PET scan, or they have a lot of amyloid in their brain, indicating that they're on the track towards developing mild cognitive impairment and Alzheimer's disease. And we have 2 prevention trials underway looking at different anti-amyloid antibodies to see if they will be effective in preventing or delaying the onset of mild cognitive impairment and Alzheimer's disease. One of these is closed to enrollment, which is the first one, the A4 study, but the second one is looking for volunteers now. So people who are older, cognitively normal, may have a positive amyloid PET scan, could join this study of an anti-amyloid antibody or a placebo, of course, because all of our trials are placebo-controlled. Usually 50% chance of placebo or less in our clinical trials. And we treat with this antibody or the placebo for some time to see if it affects the course of the disease and to see if this can prevent Alzheimer's disease. So the next slide, this is a website. This is an advertisement for a website that's available to anyone who's over 50. You can go to this website called aptwebstudy.org. It is a study, but it also offers you brain games and tracks your cognitive performance. So people who enjoy doing brain games and think that this may be effective in preventing cognitive decline, which it may be, can sign into this website every 3 months, do testing, and it's no cost, it's private, secure. And if it finds that your memory is declining over time, it will send you a message and say, looks like your memory may be declining. You may want to be checked out by your clinician or memory disorders clinic, or and it's entirely optional, up to you, whatever you'd like to do, whether you want to be evaluated or not. So I would encourage anyone who's over 50 to just have a look at this website. It also has a lot of information, as some of what I've talked about tonight, on how to protect your brain health with aging and prevent memory loss with aging. So lots more information there on this website if you would like to join. It's an NIH-funded website. So, and as I said, it's available to anyone over 50.